Thank you, Amy. I'm happy to be here today to participate in Newborn Screening Awareness Month and share at least one of my experiences with the newborn screening system in California. I will go through a case talking about how newborn screening worked in my practice, and in this case especially. Um, and then I'll go through the responsibilities and interactions that were required of me as I helped this family work through the system, the confirmation, which was confirmed in this case, and the workup of the screen positive result. Then we'll talk a little bit about a management, and we'll be able to give you some outcome because we're far enough out with this child. My first thought is to talk about newborn screening in general, and that realize it's a program, it's not a test. Um, it begins with testing of all babies in the first days of life for certain diagnoses and disorders, conditions that can hinder their normal development. But beyond that, it includes follow-up evaluation, confirmation, short-term follow-up, long-term follow-up treatment, and data collection. And overarching, this is a quality assurance and quality improvement segment of the program. It is state mandated, the United States, that is run by individual states. They are not uniform exactly in what they do, but they're getting better all the time. And I think almost all scientists, physicians would consider this one of the most successful public health programs in the world. So let's jump into my little friend Dylan, who's a patient of mine. He was born at term, 39 weeks. Via spontaneous vaginal delivery to a 30-year-old Gravida2 Para2 A0 Asian female with an uncomplicated pregnancy, labor, and delivery. His newborn hospital stay, which was 2 days and a half maybe, was unremarkable, with the exception of failing his hearing screen at 40 hours of age. So until 40 hours of age, this would be the classic well baby that all of us as pediatricians and family physicians see on pretty much a daily basis throughout our practice careers. And there would not be any obvious red flags or reasons why you would further evaluate Dylan until he had his screen done. So in California, the California Newborn Hearing Screening Program was mandated in January 1st of 2008. The program began pilot studies in 2004, and my pediatric and internal medicine practice group was involved in part of the pilot studies between 2006 and 2007. And then with the intervention of the legislature, mandated screening began in 2008. Young Dylan was born in 2010. So number one, why was this mandated? Well, hearing loss in newborns is actually pretty common. 2 out of 1,000 babies will have some hearing loss when evaluated using this system. That puts it pretty high on the list of things we screen for in newborns in general. And second, most importantly, is we know that if diagnosed and dealt with, treated prior to 6 months of age, the outcome is enormously better than those who are diagnosed later in life. And this is why it's important that Dylan was born in 2010. If he was born in 2005, he likely would not have been diagnosed till around 2.5 years of age, which is the average age of diagnosis for children with congenital hearing loss prior to newborn screening being introduced. He probably would have lost his opportunity in time to really make the kind of progress he needs to have a normal function. So in California, the initial inpatient screen is with auditory brainstem response, which is a simple, relatively simple, non-invasive, and easy to perform test, just using some earphones and some click sounds that are sent through the auditory nerve to the brainstem, and then the response is measured. It's very effective and, again, relatively easy to do. And those who fail one or both ears are then referred for follow-up as an outpatient screening. An outpatient screening is really using pretty much the same method, ABR plus otoacoustic emissions, OAE, uh, and it's just done in a more controlled environment. Instead of trying to get it done before the baby goes home, it can be done in this outpatient setting, which is in our case in the same city. And those who fail outpatient screening have then failed screening. So screening being defined as the um, as finding those with a risk, and then diagnostic evaluation needs to take place. And in California, we refer them for a diagnostic audiologic evaluation at a designated center of excellence, which are scattered throughout the state. And the last year that I could find statistics for, we screened 96% of newborn infants in California for hearing loss. So look specifically at Dylan's journey. He had his initial screen at 40 hours of age, as I mentioned, with ABR, and he failed screen was the answer bilaterally. That is, both ears did not pass the screening device, and was referred for the outpatient screening as we talked about. So this is the point where I need to sit down with families and talk about screening versus diagnostic, so they understand the process. That screens are to identify asymptomatic patients who are at risk, so it's a very sensitive test. Picks up lots, but it also picks up some that actually don't have the problem. And that's what it's designed to do. Whereas diagnostic testing is to diagnose a disease or disorder in a patient who has either failed a screen or has a sign or symptom that makes one be able to hone in on a diagnostic test. And these are very specific, so more accurate if you think of it that way. So Dylan's initial screen, after discussing with the parents, they understood the process of following up with a second outpatient screen. We arranged that visit. Our goal is getting the first screen done in the hospital before the patient's discharged. That's not always possible, but most of the time is. Our goal with the second screen in the outpatient department is to achieve that in the first 30 days of life. Dylan was screened at 10 days of age and failed screen bilaterally. At that point, Dylan is referred to UCSF Benioff Children's Hospital in Oakland, who is our designated center of excellence for the diagnostic evaluation with the pediatric audiologist. And our goal is to have that evaluation completed by 3 months of age, if possible. And he was tested at 7 weeks of age with the previous testing modes, as you can see, plus pure tone audiometry and play audiometry. So the audiometric diagnosis that is based on all of the evaluations that have been done. We're in the midst of doing other things, which we'll come back and talk about in a minute. But his audiometric diagnosis was congenital, bilateral, severe, sensorineural hearing loss, as you see on this slide. So all of those words are important and very distinctive. Congenital means present at birth. That's pretty obvious in this case. Bilateral means both ears, pretty obvious. Severe is a designation based on decibel loss. So if you have a 71 to 90 decibel loss in the speech range, you have a severe loss. If it's greater than 90, it's a profound loss. Most of the severe to profound actually sort of range between those two at different times when they're tested. Sensorineural is the damage to hair cells in the inner ear leading to deafness. It represents by far the vast majority of children with severe to profound hearing loss. Probably 90% will have sensorineural hearing loss. So with this diagnosis from the audiologist, we then have to look at a differential diagnosis of what can cause this problem, because that's not a specific diagnosis, it's a diagnosis of what's going on with the hearing system. So if one then looks at a differential diagnosis, which I've listed here, for sensorineural hearing loss, we see the following groups. One is the most common, which is non-syndromal hearing loss and deafness, also called DFNB1, which we'll talk about a little bit down the road. And it is what it sounds like. It's non-syndromal. It is a pure hearing loss and deafness disease caused by a genetic gene variant. Second is environmental, and that's a huge group, obviously, and probably by far the second largest group, which includes cytomegalic inclusion virus and a number of others that are not nearly as common as CMV is. It can be caused by perinatal problems, extreme prematurity, low APGAR scores. A risk factor is being in the newborn intensive care unit for greater than 48 hours, merely because of things that happen in there, such as meningitis, encephalitis, ototoxic exposure to drugs, antibiotics specifically, and other events. And then we have three specific syndromes that have congenital sensory nerve hearing loss and don't have any other external features that might tell you had a syndrome going on here. One is Usher syndrome, which is the hearing loss plus a ophthalmologic disease called retinitis pigmentosa, which causes eventual blindness. The retinitis pigmentosa doesn't show up until adolescence is typically. So if one had not looked for this or tested for this, you might not know until then. Then we have Pendred syndrome, which is hearing loss with associated thyroid abnormalities and vestibular dysfunction, frequently diagnosed because these children will not be able to crawl, walk, run in appropriate time frame due to the vestibular problems. And the bottom one, Jervell and Lang-Nielsen syndromes, are syndromes that are associated with hearing loss, and long QT syndrome, which presents as syncope or sudden death, and actually, sadly, is not a common but an uncommon cause of SIDS. So this is sort of the group we're looking at going into the process, and here is sort of the reasons that we want to do that. Why do you need an etiology? Realizing that if you look at all those causes, that most are not this. Most severe to profound hearing loss is not going to improve. There are things we can do to make it better for the patient, but there's, as in the past, has been questions of why do you push diagnosis to find an etiology, and the answer is as follows: you can have some prediction of progression in natural history. Important for a family to know this is potentially maybe going to get worse because some of these progress, is not likely to improve, which is true of almost all of them. What the normal natural history is in whether treated or untreated. Two, associated physical conditions. We just talked about Lang-Nielsen, for instance. If you knew that was the diagnosis, you would obviously do an EKG, get this child in the hands of a cardiologist, and deal with that potentially life-threatening process right from the beginning. Three is we no risk for other family members. Depending on how the family history shows up, what we find, that may include siblings. Dylan actually has a 3-year-old sister at the time he was born, so her risk would be involved in that. And it could be to extended family members, depending, again, on what we find when we do genetic pedigree. Obviously, appropriate intervention. Many of these can be dealt with either hearing aids or cochlear implants, and if you knew what you were dealing with, that would get that going at an appropriate time. And ultimately, accurate counseling. So that counseling would involve the parents to begin with, in terms of this disease and recurrence rates and such, but eventually involves extended family, potentially. In this case, the 3-year-old sister at some point would need some advice from the counseling system, and ultimately the patient, although his need is a little further out in this case. So the medical workup really has these 6 windows to them. Obtaining a prenatal and perinatal history and risk factor to know what those issues are. Taking a full family history, at least 3-generation family history. We've already talked about the reasons for that. Physical exam, obvious, with some very specific emphasis, which we'll talk about. Laboratory and imaging will depend much on the first 3 issues. If we have reasons to do, some of the labs will do on everybody, but most of the labs will be only as indicated. Everybody needs a referral to an ENT or otologist, in that they're going to be the folks who are running the show regarding getting therapy going. And then other special referrals as indicated, and that could be as diverse as ophthalmologists who are very typically involved in these patients, um, geneticists, uh, and cardiologists. Depending on what you find, they often need other subspecialty referrals. So to go through those one at a time, the prenatal history, excuse me, there's a few specific things: ototoxic medication exposure um, for the mother. These are typically antibiotics, but there are other drugs that can, in fact, affect hearing development. Pregnancy complications of any kind, you certainly want to know about. And a maternal rubella immune status, as rubella is one of the most common infections that causes hearing loss in folks. And then use of maternal drug use or alcohol use. So these were all negative for Ryan, non-contributory to figuring out what was going on here. Perinatal risk factors, I already alluded to, being in NICU, intrauterine infections, pretty obviously, will things like group B strep can be devastating to hearing. Any craniofacial or external ear anomalies, that makes pretty common sense that you are more likely to find functional problems if you have physical anomalies. And of course, looking for syndromic stigmata to make us then look at the many other syndromes that have hearing loss, but have stigmata that you can see when you see them as a newborn. Again, Dylan was negative on all of these. None of these were contributory. He had no anomalies of any kind. Had a clean newborn history. Family history, typical, 3-generation family history, looking for, in this case, specifically members of the family who had a hearing loss before 30 years of age. We always are sort of looking for consanguinity, potentially, especially if we're dealing with autosomal recessive diseases. And we're also seeing if there's a pattern of inheritance of anything that might fit this in the family. So we did this with Dylan's family, and we had one hit in that the mother said she had an aunt who was deaf, and she didn't know her well. Her aunt still lived in China. The family was eventually did contact her, and we found out some weeks later that she'd been deaf since at least childhood. So it is very likely that she, in fact, had this as well. But it wasn't actually confirmed. We couldn't get any medical records. And all other family history from them was non-contributory. I did mention he had a 3-year-old sibling, and the family was otherwise healthy. So physical exam, the usual, pay attention to everything, but the special attention to anomalies, realizing that if you find one minor anomaly, these are usually minor is sort of defined as having cosmetics, something you can find but usually doesn't have functional significance, like having a single palmar crease on a hand or having an ear tag, something like that. If you find one, you have about a 3% chance of finding a syndrome in that child. If you find 3 minor anomalies on a patient, it goes up to 20%. So that's a pretty big jump all of a sudden. And if you find one major anomaly is as defined as having functional impact, such as a hole in the heart or some other congenital anomaly, then virtually almost, not all, but almost all of those will be definable as having a syndrome. Poor intrauterine growth or intrauterine growth retardation is a high-risk feature for a number of things, such as infections and other genetic abnormalities. So it's a marker that we look for in physical exam. Microcephaly, small heads are almost 100% associated with neurological dysfunction. Hearing might, of course, be among those. And any other neurological abnormality, we're always looking for that in our first exams of newborns anyway, but special emphasis because of what we know about a screen. So for Dylan, these were all 0. He had no other anomalies. He had good growth. He had a normal size head and looked like a perfectly happy well, baby newborn. So we move on to some labs and or imaging. A urine culture for CMV is done on almost all children, and should be probably all children with congenital hearing loss. His was negative. Storch titers, which is syphilis, toxoplasmosis, rubella, CMV, and herpes virus, as indicated. So if you had a history, maternal history of herpes, if you had any physical findings, rashes, petechiae, etc., you would do that. We did not have any indications; it was not done. Array CGH, which is comparative genomic hybridization, is indicated if you have significant dysmorphology. So if you found major um, or minor anomalies, this would be the next step. Now, a few years ago, this would be chromosomes, and many of you watching this today will have ordered chromosomes in the past. I think in the last few years, it's become obvious that the array CGH is um, uh, more efficient, uh, faster. It gives you pretty much the same answers, and is easier to come by. EKG of cardiac issues. Dylan had none, and had no reason for us to do a CGH or chromosomes. Skeletal surveys, X-rays for growth delayed or disproportionate, such as dwarfism syndromes. He had none of that, so we didn't do that either. And then a head CT or MRI, if indicated, for the structure of the middle and inner ear. And this is indicated in asymmetric hearing loss. So if you had purely unilateral, one-sided, or if there was a big difference in the sides on how much loss there was, this is a good appropriate test to do next, because you'll frequently find anomalies of the inner ear. If there are anomalies of the external ear, then this is a good test to go to as right away. And we also come back to this if we do all of the other testing, which we'll go through in the next couple of slides, and we don't get an answer. Then one reverts back to looking at this again. So for Dylan, we didn't do most of these because they weren't indicated, and those that were done were normal. So moving on then, the next step would be molecular genetic testing. Reason is over 120 gene variants are associated with non-syndromal hearing loss, and that number changes literally by the month. So that's why the term over. Most of them are recessive, as you can see. A significant minority are autosomal dominant. A few are X-linked recessive, and a very few are mitochondrial. So in this case, we ordered a non-syndromal hearing loss panel. It's just called that, and it was by a commercial company. It had the contract with California for that next test. It happened to have tested 95 genes using sequencing and deletion duplication analysis. The results of that test were as follows, as you can see. So first of all, the use of a panel like this is probably the gold standard in evaluation at this point, although some folks are using whole exome sequencing. I should mention that, and that would, of course, do the job as well. So that may change in the coming years as well, as we're looking at both of those. So to go on to our results, biallelic pathogenic variants in GJB2. So GJB2 is a gene that's very commonly associated with congenital hearing loss. It is the gene that produces Connexin 26 protein. You'll hear that term used a lot in these non-syndromal hearing loss patients, that they are Connexin 26 patients. So let's go over the words again. Biallelic, it means both alleles. That is both the gene that they got from their mom through the sperm or through their egg, and dad through sperm, were both pathogenic variants. And in this case, they could be heterogenic. They could have different variants that were pathogenic, and the two of them together create the disease, or they could be the same. And in this case, they were the same variant. This is by far the most common gene associated with congenital hearing loss. It's located on the long arm of the 13th chromosome at 13q12.11. And it is an autosomal recessive disorder and has been given the designation DFNB1, which you'll see in the literature a fair amount if you're looking at this. So Connexin 26, just to go a little further with that, it's a protein produced by this gene. It's a gap junction protein, hence the GJ of the GJB2 designation, and it is necessary for cells to communicate with each other. The gap junction is the junction between two cells in any functional setting. Without Connexin 26 or enough Connexin 26, the potassium flow from hair cells is disrupted in the cochlea, and it leads to severe damage that is not fixable, leading to severe to profound sensory neural hearing loss. So 50% of all severe to profound autosomal recessive non-syndromic hearing loss in the US is going to be due to variants in this category of gene. So the prevalence is about a 1 in 7,000 if you look specifically at this diagnosis in the United States. The hearing impairment is isolated in this case. That's important. There's not other parts to it. There are no cardiac, renal, other neurological issues that one needs to be looking for. Not that they couldn't occur unrelated, but in a related manner, this is a pure hearing loss. And this particular hearing loss does not vary with time. So the variation between severe to profound is one of testing, basically, as opposed to what's really happening. But this is one that does not progress, nor does it improve. We then did extended genetic testing to look at the family. Once we identify what the actual variant is out of those 120 plus possibilities, we're then able to much more easily test other people in the family because we only need to look at the variant that we found. So in this case, we did that, and both of the parents were carriers, of course. You would expect that. And Dylan's sister, unfortunately, is also a carrier. She's unaffected, and that's important to realize that not all autosomal recessive diseases are like this, but most are, and that is that carriers are asymptomatic. That there really is no impact to hearing or anything else with the carrier, so they would not be found without genetic testing. So that took us to management, and in the management world, he was referred to pediatric ENT and audiology. There is a specific group in our area that actually, for most of the East Bay, does all the congenital hearing loss children. Specifically started with hearing aids because they can be fitted early. He was fitted by 4 months of age, which is excellent. We like to. Our goal is 6 months on getting aids going if they are appropriate. And at the same time he was being fitted for that, he was being evaluated for a possible cochlear implant. And that takes a long time, as it turns out, and it takes a fair amount of counseling and learning for the parents as well. And in the California system, a cochlear implant cannot be done, or is typically not done before 12 months of age. So all that being what it is, he was successfully implanted at 16 months, which is very nice. We'd love to get that done before 2.5 years of age, if possible. General rule is earlier is better. It produces sounds that aren't like speech sounds, but they're sounds that the patient can learn to understand as speech, and are a dramatic habilitation device for the congenitally deaf child. I also referred him to an education program at the Center for Early Intervention and Deafness, SEED, in Berkeley, which is basically for children 0 through 6 years of age. And it's a very interesting concept. They also have a preschool and kindergarten for normal hearing children. And so they have the classes mixed with each other about half the time. And it's actually a wonderful experience for both the hearing impaired children and the normal hearing children. Um, and he received a speech pathology referral to a certified speech pathologist in our area who has worked with deaf children for a long time. So I'll give you the follow up. The long term follow up is Dylan is now entering fifth grade in what would be a mainstream classroom, except for COVID. So he's now a mainstream laptop, I guess. And he's actually doing quite well. A very nice family has done very well with this. They did not have any more children, so um, he now has a 13-year-old sister who is getting to where we may have to talk about how this impacts her reproductive life. I think Dylan is a shining example of the success of a newborn screening system that he wouldn't have been picked up without it. Things went well, and his future is totally different than it would have been. So the last thing I'll mention quickly is genetic counseling for an autosomal recessive disorder. I think we probably all know this, but one more time, we'll talk about the risk for future pregnancies. 1 in 4 chance of having a deaf child, if you know that you're both carriers. A 1 in 2 chance of having a hearing child who is a carrier, such as Dylan's sister. And a 1 in 4 chance of having a hearing child who is not a carrier. The other parts of counseling, once you know the gene, the variant, is prenatal testing would be available if one wanted to do that during pregnancy. And pre-implantation genetic testing could be done before artificial insemination. So I am fortunate in that my wife is a certified speech pathologist, has her master's in speech and audiology, and worked for a long part of time of her life with children with hearing disorders. I learned something important, and that is that many deaf individuals and families, although they're interested in obtaining information about the etiology and about the genetics, it's really informational rather than for reproductive risks. It's important to ascertain where your family is or where that individual is, because in contrast to medical model, the way I think of deafness as a pathologic condition, many in the deaf community do not feel themselves to be handicapped at all, and they define themselves as being part of a distinct cultural group with its own language, customs, beliefs, um, and you just need to understand this perception of risk is very subjective and very different. Doesn't mean they don't need to know the information. They do, and most are happy to have it. But I have found that there are some families I've subsequently dealt with who actually said they would prefer to have a deaf child if they had children after we had our counseling session. So it's a little different maybe than some of the others, but nevertheless, you have the information available and can give that to them. And I thank you very much for your time and look forward to any questions or thoughts.